Welcome to today's webinar, Engaging Patients in HIV Care, Understanding Intimate Partner Violence and Its Implications for Treatment. I would like to introduce Tami P. Sullivan, PhD, Associate Professor at Yale University School of Medicine in New Haven, Connecticut. Welcome, Dr. Sullivan.
Thank you. Welcome, everybody, to this webinar. Thank you for your interest in this very important topic. The slide title, let me switch one more. This is important for you to know. In the chat box, please do type your full name, and that's the name that you use to register for the webinar, and the institution. This will verify attendance and allow you to be eligible to claim your credits. Only pre-registered attendees can claim CME, nursing, or pharmacy credits, or a certificate of participation for this live webinar. In terms of this next slide, if you haven't already previously logged on to the new website, you'll need to use your new email address and reset your password. In terms of CMEs, IAS-USA designates this live activity for a maximum of 1.25 CME credits. And it's also approved for 1.25 hours of nursing and pharmacy credits. Support for this activity, generous support for this activity, has been received from the following contributors. And so that you know about navigation, there's a separate window that will show poll questions for you. You can choose your response from the poll, not in the chat box, and responses will be displayed after the poll closes. So please type your questions into the chat box, but the poll responses into the poll. So this is the first poll for you. From which geographic region are you viewing this webinar? And I apologize for technical difficulty. There we go. Okay, we're all set. And the second poll, please rate your level of experience in the medical management of HIV infection. Excuse me, the poll is closed, and we can move on to the next slide. Okay, there's your title slide that you've already seen. And full disclosure is that my spouse is employed by and holds stock and stock options in Achillian Pharmaceuticals. Okay, so let's dive into learning objectives. So upon completion of this webinar, what you'll be able to do is identify signs of various forms of intimate partner violence, which I'll refer to throughout the webinar as IPV. On rare occasion, you'll hear me say DV for domestic violence. The two are interchangeable for the purposes of this presentation. You'll be able to describe the extent to which IPV may impact your patient's abilities to engage in care and follow through with treatment recommendations. And then finally, you'll be able to create a context or an environment that supports engagement of victims of IPV, and we'll walk through some specific steps that can be helpful toward that objective. So in terms of our pretest question, there are various forms of intimate partner violence that can influence patients' engagement in care for HIV, both directly and indirectly. Which is the most frequently occurring form of IPV among female victims? Physical, sexual, psychological, or financial? Okay, and the poll is closed. Okay, and so I'll tell you the answer in a moment. In terms of myths or misconceptions, or perhaps media presentations, so you can see here the first bullet says, victims are fragile, helpless women who could have been abused by angry, mean, psychopathic men who could easily be identified in one interaction with them. Victims are severely physically abused, have extremely low self-esteem, and fear for their lives on a daily basis. Now, if we were in the same room together, I would be able to see the number of you that are probably rolling your eyes thinking, oh my gosh, do I have to listen to this woman for the next hour? That's such a stereotyped version of a victim. And that's actually why I'm putting it up here. It is a very stereotyped version of a victim. First of all, the first bullet is very pejorative. To call victims fragile and helpless is really is just offensive. And the people who experience intimate partner violence aren't only women, it's men as well. And not everybody is severely physically abused and cowering in the corner and fearing for their lives on a daily basis. And so I really want to start out with us all on the same page about the range of partner violence victimization. And I really hope that over the course of this webinar, at the very, very least, I broaden the scope of understanding about what partner violence includes. So in terms of intimate partner violence, I promised you that this is the only slide I will really read word for word. Partner violence is the use or attempted use of physical, sexual, verbal, emotional, economic, or other forms of abusive behavior with the intent to harm, threaten, intimidate, control, isolate, restrain, or monitor another person. In 2019, I rarely have to explain what qualifies as physical abuse. Again, media presentations most often speak to severe physical abuse, and it includes that, but certainly by no means is limited to that. So physical abuse can include, grabbing, pushing, hitting, punching, someone putting their arm up against another person's throat. Sexual partner violence, when we think about sexual abuse, we often think of sexual assault. At least 10 years ago or more, we would think about someone hiding in the bushes, waiting to, pounce on a female jogger who's, walking by or jogging by. And we had this idea that we always needed, as women, to be afraid of strangers. Thankfully, with the Me Too movement, there's more awareness that sexual abuse often occurs in the context of known relationships, but we still rarely take it to the point of understanding that sexual abuse occurs very often in the context of intimate partner violence. And it's not just rape or penetration, it's the experience of any unwanted sexual behavior. And that can happen through verbal coercion or the use of force. And then finally, at the bottom, we have psychological abuse, which is actually the answer to the poll question. Psychological abuse occurs more frequently than any other form of abuse in relationships where there's intimate partner violence. And it really spans the spectrum of severity, and the implications are pretty broad-ranging as well. So belittling remarks, put downs, swearing, calling someone names, monitoring where they go, who they're with, restricting contact. Things like that all fall under psychological abuse. And we'll get into greater detail later about why this is critically important to understand for the patients that you care for. So I'm going to start with an explanation of daily experiences of intimate partner violence to just provide greater depth about these experiences. We're going to start with the first question, though. You're a woman in a relationship with a male partner who's physically abused you. Over a 3-month period, what percentage of days are characterized by the occurrence of some form of intimate partner violence? Okay, so we have a pretty interesting range across the four response options, with anywhere between 21 and 28% of people, so fairly evenly distributed. We're going to go ahead to that next slide to show you what the distribution is. So to tell you bare bones about this study, because I'm sure you don't all want to be bored to death by research, this was actually a study we did a while ago where we looked at the daily experiences of victims. So people called in to report their experiences the prior day. So we were able to characterize their days by the types of violence experienced. And what you can see on the top line where it says no IPV is that on 62% of days, no partner violence occurred. None. And that includes psychological abuse, name calling. So on 62% of days, no partner violence occurred. And I'll talk about the implications for this in a moment, particularly regarding how we understand partner violence. But you can see next that psychological partner violence only by itself occurs on 27% of days. It is the most frequently experienced type of intimate partner violence. And you can see in the rows below that it frequently co-occurs with other forms, or I should say that physical and sexual abuse almost always occur in the context of psychological abuse and rarely by themselves. So if you look at the bottom of the table where it's barely highlighted, you can see that sexual partner violence occurred by itself only on 0.6% of days, physical IPV only on 0.3% of days, and physical and sexual together in the absence of psychological happened never in the context of this study. So psychological abuse alone on 27%, combined with the others, it's about 38% of days, somewhere around there, 37% of days. And for me, this really speaks about the critical importance of attending to psychological partner violence if we're to prevent it, and what co-occurs with it more often, which is physical and sexual abuse. So what are the implications of this, and why am I inserting this data into this talk? Well, it helps us understand victims better. In these slides, you'll see that women is in parentheses, and that's because the study was done among women, and we're not clear how well these data generalize to men. So as not to overstate what my findings show, I have the words women here in parentheses. So the finding that on most days no partner violence occurs helps us to understand the ambivalence that some women experience about ending their relationships. I can tell you in the context of the research that I've done over almost 18 years, I've interviewed over 1,500 victims, and rarely do people want the abuse to end. More often, they want the violence to stop. Now, of course, that really depends on the severity of the violence, the supports they have, how invested they are in their relationship. But women often talk about wanting the violence to stop, not the relationship to end. And this prevalence shows us that it's not happening every single day. The breaks in between the incidents of partner violence likely contribute to minimizing problems in the relationship and instilling that hope that partners are going to change their abusive behavior. Because this is what's often told to the victims, right? People hear, I'm sorry, I had a bad day at work, it's not going to happen again, or things have been really tough with the kids at home and I just lost it, I really love you, don't leave. Those kinds of things happen. They minimize the abuse, and the breaks in between incidents likely contribute to that. Now, the findings here are also in contrast to presentations of IPV in popular culture media that most often depict severely physically abused women and abuse happening every day. So there were a fair number of folks who selected that they assumed partner violence occurs on 90% of days, and that's because that's the idea that we get from the media, and it really misrepresents the experiences of victims and does a disservice. The reason for that is it doesn't accurately represent all women or all victims, right? And so it doesn't allow people who don't look like what's presented in the popular press to think that they're in a situation that warrants support or services, and that includes women, men, children, and families. Also, these findings really underscore the importance of attending to psychological IPV, and the idea that if we're able to do more to reduce that, the data suggest that we can reduce the occurrence of physical and sexual IPV. And you'll see at times on the slide I have very tiny font, and those are the references for citations. So intimate partner violence and HIV. What is the connection? Why is there a need for this webinar? So question number 2, what percentage of female IPV victims live with HIV? Okay. So the answer to that should probably be a little clearer. It's in the second bullet, and I'll share that with you in a moment. But women who do experience IPV are more likely to become infected with HIV than women not in abusive relationships, and that rate is about 48% times more, or 48% more likely. The answer to the polling question perhaps should have been a little bit more explicit. It's 10% of women currently experiencing partner violence are living with HIV. And even that rate among current victims is almost 10 times the prevalence of women in the general population. We know that there are various ways that partner violence can increase HIV risk for women, and in the context of the webinar, I really don't have a tremendous amount of time to go into great detail about the various paths. There's some great studies and papers out there on it, but suffice it to say for the moment that abusive partners can increase risk because they may be HIV positive, they may be engaging in risky sexual behavior, injecting drugs, or forcing victims to have sex without protection. So what percent of women living with HIV experience IPV? Okay. So the answer to that is about 55% of women, and it's about 24% of men living with HIV experience IPV. And again, that's double the partner violence prevalence among women in the general population. We really, sadly, don't have great data about men and partner violence, and we'll talk a little bit more about that later in the presentation. We do know in terms of HIV disclosure among women that 24% of female patients experienced abuse by their partners after disclosing their HIV status. So, does partner violence, does IPV matter to HIV treatment planning, adherence, and engagement in care? Well, I'm assuming that I'm speaking to 158 people because you all believe that in some way it is, which is a great start. I'm going to give you a specialty-specific example first. So I'm assuming there are some OBGYNs on the call, and even if you're not, you can certainly relate or understand this example. Think about if you routinely screen for gestational diabetes or preeclampsia. And again, if we were all in the room together, I could see the number of folks who are nodding their heads and raising their hands and saying, of course, yes, definitely. But the fact of the matter is abuse is actually more common for pregnant women than gestational diabetes or preeclampsia, which usually surprises most folks. So it does really matter to the care you provide, and not just to OBGYNs. And the reason is, this is a great little wordle from CDC, intimate partner violence victimization almost across the board is associated with higher rates of all sorts of physical and mental health problems, everything from HIV and AIDS to migraines. I mean, you can see this list, PTSD, joint disease, asthma, central nervous system disorders, bladder infections, chronic pain. These aren't even all of them. This isn't a comprehensive list. But regardless of what you do and if you have a specialty, intimate partner violence affects engagement in care and folks' ability to follow through with treatment. So we actually did this project here in Connecticut where we interviewed women, again in particular, about how intimate partner violence affected their care. We interviewed both women who were currently being abused, as well as those who had been abused in the past while they were diagnosed with HIV, but that they were no longer in an abusive relationship. There were really 4 themes that emerged about how partner violence affects care. And here, this is specific to HIV. This is what the project was about. It's what it was focused on. So first, we learned that partners actively interfere in HIV care. So he used to fight with me and make me not take my medicines. Well, it got to a point where you don't want me to go nowhere, you know. I actually work with a close colleague, Jamie Meyer, who does research on this population as well among women in prison. And one of the quotes I think that hits it home for participants a lot that I share is that she had a woman that she was working with who shared her partner used to flush her medication down the toilet, her HIV meds, and say, you know, look, now you're going to die faster. And so there's really no way around describing that. That's pretty active interference in HIV care, and that was the first theme that emerged. The second one was that partners passively interfered in HIV care. So the first quote is, sometimes he would get mad at me and not take me to my appointments, or he'll forget. Well, he says he forget. So it's not the direct in your face, not allowing someone to take their medication, not picking it up from the pharmacy on purpose, flushing it down the toilet. It's a little more passive than that. It's the, oh, I didn't remember you had an appointment kind of thing, which can obviously interfere with labs being drawn, you know, art being prescribed, et cetera, or refilled. The third theme that emerged was that women's self-worth was so affected by the partner violence that they don't engage in self-care. And we had a ton of quotes around this that illustrated this issue very, very well. But we selected the following 3 as exemplars. When I was with my ex-boyfriend, I didn't take good care of myself. But as soon as I got out of that relationship, it's like everything fell in place. I started dressing more, taking care of my health. The second person said, no, I wanted to stop myself from taking the HIV medications so like that I could die. That's how bad my nerves were, what I was going through. I just wanted to like die slowly. The last person said, I got hooked into him. I stopped taking care of me and started taking care of him. And this came up, as I said, repeatedly, and it's also critically important because it's often tied back to what I shared with you as the most prevalent form of intimate partner violence, which is psychological abuse. So we know there's a ton of evidence, not just from my own program of research, but from others as well, that shows the detrimental effects of psychological abuse. It's actually associated with HIV risk behavior. It's a stronger predictor of PTSD than physical or sexual abuse. There are a number of other ways in which psychological abuse is really, really harmful. But this really highlights how it can interfere with people's own engagement in care. They just don't care anymore. The fourth theme that emerged, the final theme, is that physical harm can impact relationships with service providers. So sometimes it was always, I was bruised. And then, like I said, I didn't want anyone to see that. And I had refused to call the police. So I guess I was dodging the doctor, the police, and everything. And this is really where people avoid others who might be able to detect that they're a victim of partner violence. And so they avoid going to care. They avoid seeing you because some folks know how to detect IPV. You know to look for the bruises on the back of the arm, the 3 fingers for the grab mark or the thumb, or you're savvy at screening. So they avoid. Or, you know, clearly if there's a black eye or things like that, questions that you ask, they might not be able to explain away. And so instead, they avoid attending care. So to speak to intimate partner violence and HIV, why can't we just ask people? Like, you know, the new patient forms that say, is there a family history of heart disease? You know, do you have asthma? Do you have diabetes? Why can't we just ask on those forms and expect to get an honest answer? Are you a victim of intimate partner violence, or have you been? There are a lot of barriers to disclosure of partner violence victimization, and some of them overlap with barriers to disclosure of HIV. There's shame and stigma, and intimate partner violence can be a concealable, stigmatized identity. So for some people, if they don't disclose it to themselves, other people would know. So that's a way to avoid that stigma. The other issues that come into play are around fear. For victims, there are all sorts of fear that can come into play here. They're afraid they might get blamed for their own victimization. This happens. They're afraid that others will socially disconnect. We as providers wonder about if the children are at risk and they're afraid of losing their children. Depending on the state you're in, there are policies and laws that guide whether or not police officers need to call local child protective agencies if there's disclosure that there's partner violence in the home. So there's lots of fear around victimization disclosure. There's issues around gender, race, and sexual orientation. It is much more difficult for a male victim to come out and disclose that he has experienced intimate partner violence. There are issues of stigma in the community around that. And also, sometimes it's difficult to get help because services are not offered specifically for men, or sometimes what happens is that men will call the domestic violence hotlines looking for services themselves, but they're questioned in a way to suggest that they could be an abuser trying to find out where the local shelter is. Now, it's completely unfortunate, and I'm not supporting that at all, but it happens all the time that abusers call hotlines trying to find out where the shelter is. But that makes it even more difficult for men to disclose. And then, of course, depending on someone's gender identity and who their abuser is, it makes things even more complicated. Previous disclosure of partner violence is a really important factor that contributes to whether or not they'll disclose to you, or if they disclose to you, if they'll disclose to anyone else in the future. So I'm going to give you an example that I think helps speak to this. So this was many, many years ago. I was working as part of a treatment team in an intensive outpatient program. There was a patient who was having difficulty in a dual diagnosis group, so for mental health and substance use. And it was clear that the issues going on in the group for her were really around trusting people. And I mean, it was very obvious. She was pretty explicit. And as we were talking in the treatment team meeting, I felt the need to really remind folks that this woman had a horrific, it happened to be a sexual assault history when she was a child, but it's the same kind of issue. And I said, I want us to remember that she has a pretty horrific sexual assault history. And the psychiatrist who was the treatment team leader said, oh, get over it already. It happened when she was 9. So again, if I were in a room with you, I could see all of your faces, most of which would be wide-eyed and thinking, oh my God, that's awful. But if that patient had disclosed to that psychiatrist who was her primary treater, I don't know what happened behind closed doors. Did the psychiatrist minimize that? Did she blame the patient? And so how that provider reacts to that patient has implications for whether or not that patient is willing to disclose to others going forward. And so that's really important to understand as well. Sometimes people are invested in the relationship with the partner. As I said before, they don't want it to end. Lots of times, we're learning this in a national domestic violence homicide project that I work on. A lot of reasons that victims don't want to tell anybody else is they don't think that it's serious enough. It doesn't qualify as what they see in the media. They're not fearing for their lives on a daily basis. They don't have a black eye or broken bones. Another reason is that there can be a potential mismatch of goals. So as providers, we have ideas and knowledge about why it's important for people to disclose partner violence. But the reasons that we have in mind and our goals for understanding that may not match with what they want and what they know they need or believe they need as a patient. So that's another reason they don't disclose. They might not need or want the kind of help that you or I can provide. And then there's the media influence thread, which I talked about. So do victims and survivors want you to screen? Well, in one study by McCloskey and her colleagues, they identified that about 8 out of 10 victims said that they did want their providers to ask, and you can see the word privately in here. They want them to ask privately about their partner violence. So 8 out of 10 victims said yes. Now, that doesn't mean they're going to disclose, but they do want to be asked. And of those who were asked, right, when victims who talked to their healthcare provider, they were 4 times more likely to use an intervention and 2.6 times more likely to exit the abusive relationship. So the great news for all of you that are taking time out of your day to be on this call is that you do make a huge difference. You can make a huge difference. So then the next question is, should you as an individual screen for intimate partner violence? Well, only if you're prepared for the response, because I can tell you if you are not prepared for the response as an individual, or let's say as a clinic, if you're doing this in the context of a clinic or a program or a center, and you're not prepared for what's going to happen after that, it actually can be more harmful than helpful. So I'm going to walk through some strategies that you might consider using for screening folks so that you can feel better prepared for the response. So it's important to lead this discussion with whether or not the goal is detection and disclosure of IPV. So some systems or providers have detection of IPV and the victim's disclosure as their primary goal. If this is your goal or your system's goal, you're going to want to use more direct methods of screening, and I'll walk through those in a moment. But others don't have this as the goal. So if detection and disclosure is not the central focus, there are other strategies and other approaches that you can use that can raise awareness about healthy and unhealthy relationships, that can help people understand the impact on health, that will still provide victims and survivors with resources, and will also let the patient know that they can talk to you about IPV if they choose to. So I'm going to walk you down these two paths. In terms of direct screening, so the U.S. Preventative Services Task Force just put out recommendations at the end of 2018 where they recommended screening and referral to ongoing supportive services. So they believe that the evidence supports screening only if you're going to refer to ongoing supportive services. And they suggest at least 5 direct screening instruments. A lot of these are very brief, like 4 items. So they can be integrated into a medical record system, a personal history review for the patient, something you could do on paper or just memorize. And they're direct screening instruments. So there's the HARC, the HITS, the E-HITS, which requires a little bit of scoring, PVS, and the WAST. The evidence that was presented in the Preventative Services Task Force was really for women of childbearing age. They believe that there's not enough evidence yet for screening for partner violence in elders or men. Some people argue that that's kind of ridiculous, that there's enough evidence to show that we should be screening everybody, but what's in that report speaks to women of childbearing age and provides those suggestions for direct screening with those instruments. The HITS, this is an example of the HITS. How often does your partner physically hurt you, insult or talk down to you, threaten you with harm, scream or curse at you? And then it suggests that a total score of more than 10 is suggestive of IPV. I tend to be someone who is not as focused on these exact measures and cutoffs. I mean, if for some bizarre reason someone says, I'm frequently physically hurt, but no one ever talks down to me, threatens me with harm, or screams or curses at me, again, that's an unlikely scenario, but because the score would only be an 8, I wouldn't say, oh, there's no partner violence there. So obviously you have to use your judgment, but the recommendation is that there's a score of 10 that's suggestive of IPV. In terms of the discussion approach to detection, again, it's still pretty direct because you're looking for a disclosure, but you can actually have a conversation instead of using the items. Now, of course, this really depends on how much time you have as a provider to spend with patients. Some folks are somewhat unlimited in their time. Other folks are limited to, 10 minutes. So you need to decide what works best for you and works in the context of the type of care that you're providing. But if you choose not to use some 4 or 10 item instrument and instead want to normalize the topic and have a discussion that might lead to disclosure of IPV over time, you can start out by normalizing the topic. And throughout the rest of this presentation, I've given you lots of examples of things that you can say to patients that help to normalize it, that would show that you're not going to be judgmental if they disclose. You can say things like, since I'm your doctor, we need to have a good partnership. I can better understand your health if you'd answer some questions about your relationship history. Or I ask all of my patients this question because it's important for me to know what has gone on in their lives. Everyone argues at home. What happens when you and your partner disagree? Now, I actually use this method in the clinical work that I do, and it's really interesting, the variability in the responses. So you will have people who say, oh my gosh, it's awful. She gives me the silent treatment, she walks out, she won't talk to me for 2 days, or he leaves, he goes over his buddy's house, and, he comes back when I'm asleep, and then we never talk about it. Okay, now personally, I wouldn't call those like the healthiest ways of resolving conflict, but there's not necessarily at the beginning any red flag. Whereas you might hear things like the following that drop a little bit more of a hint or raise a little bit of a red flag, even about psychological abuse. So things like, oh my gosh, it's awful. He screams and he yells, and a lot of times he'll block the door so I can't even leave the house. I can't. And I mean, I know I'm supposed to like take a walk or deep breathe, but he doesn't even let me leave the room. That should be a red flag for you, right? And so it depends on, again, how much time you have and what you want to follow up on, but you can follow up those questions to learn more about that and ask them if they have any concerns about that or if they feel safe. You can say, if somebody does disclose to you, I'm sorry that this is happening. It's not okay, but unfortunately it's common. You aren't alone. Or what you're telling me makes me worried about your safety and your health. So again, to go back, one slide, keeping it in the context of health as a healthcare provider, if that is your role, can be really important, right? Because your credibility as a healthcare provider is really important to the patient, and as you tie partner violence to health, it will be more meaningful to them. And again, I'll share more information in a moment about this. Evaluate the patient and their circumstances. So if your patient does disclose, you want to evaluate their current level of danger, violence, substance use, and general well-being. If I had time, I would put up a list of the highly co-occurring problems of intimate partner violence. We know, in particular with all victims, that there's a high prevalence rate of alcohol and drug use, and that folks do what's often called self-medicate. Many of you are familiar with this term, where they don't have necessarily a prescription for managing the negative consequences of being a victim, but they have their own prescription in the form of alcohol or drug use. And so substance use is highly, highly prevalent. We know that partner violence co-occurs with all sorts of other problems, and that there's a high prevalence of mental health problems. PTSD can be about 33%. It depends on the population. About 83% of women who experience intimate partner violence, even if they don't meet criteria for PTSD, about 83% have clinically significant impairment in functioning related to their symptoms. So you do want to evaluate their current level of danger. You do want to support the patient, but if you're not a therapist, it's probably not helpful to act as one, and that's because it's not like they're going to be able to come back to you frequently if you're not a therapist or a caseworker and talk to you about what's going on. So you don't want to completely open Pandora's box and have them disclose all sorts of personal and intimate details, which isn't necessarily helpful. And to be honest, it's not necessarily helpful in the context of their work with a therapist either. When patients work with me as a psychologist, I'm not asking them to disclose details of the trauma that they experience. As a matter of fact, depending on their stage in care, I'm trying to contain them so that they're not reliving the experience, or feel re-traumatized by sharing those details. So you can ask if they have someone to talk to for support. There are plenty of people who have shared this information with family and friends, and they do have someone that knows about what's going on. Not always, but often. Would you like me to explain options and resources that survivors are often interested in hearing about? Now, obviously, you'd have to know what those resources are if you're going to share that. So lots of hospitals have social workers, or clinics have people who know about the resources in the community. It's not necessarily difficult to find that information out. If you're not familiar with what's available in your area, you can go to the National Network to End Domestic Violence, or every state in the United States does have a state coalition against domestic violence, and there are the locations of all of the domestic violence service providers typically listed on their website, so you can find information there. Also, your statewide hotline can be there if you don't want to use the national hotline. You can also say something like, some survivors find talking to an advocate or counselor to be helpful. What else can I do to be helpful? Is there any other way I can be helpful? Now, with the last one, you, of course, have to be careful, because if you've got someone who's in tremendous need, it could be a very long conversation that you may not be able to have, where they may be asking of a lot of things that you can't help with. So, again, consider your role in the context of the discussion. It's also important to note here that in most states, mandatory reporting requirements do not apply to partner violence victims unless they are children, elders, or vulnerable. So I give presentations like this a lot, and there's often a misunderstanding, and I understand why, but there's a misunderstanding of participants that just like child abuse or just like elder abuse, we have to report intimate partner violence, that there's an agency that provides support for that, and there's actually not. Not that there's not agencies that can provide support, but there's no child protective services for adult victims of partner violence. So the only time, you need to check your state specifically, of course. I don't know what those laws are in each state, and I wouldn't want to be responsible for misinforming people. But a lot of times, mandatory reporting requirements only apply if there's a child who's harmed or children who are harmed, if someone is an elder, even if it's the context of partner violence to an elder. And in the state of Connecticut, an elder is actually, it's very young. It's actually 60 years of age or older, or if someone is in a vulnerable state, someone who is disabled or something like that. And again, you need to check your state requirements for what that means. But those are the mandatory reporting requirements. You wouldn't necessarily call the police if someone's a victim unless they feel unsafe, because actually calling the police can increase the risk of harm. And we don't really have time in the context of this webinar, but calling the police doesn't always result in an arrest. It rarely results in incarceration, so it actually could be doing more harm than good, and you would really only want to do that if the victim survivor said that he or she is at risk. If your patient doesn't disclose or says, no, that's not going on for me, I don't have to worry about that, you can still offer education and prevention information, and that is because things can change. And also, they might choose on one day not to disclose to you, but they might choose in the future. So making it part of a normal visit can be really useful. And then you can ask and assess again at future visits. Okay, there's a title slide missing here. Sorry about that. In terms of meeting with patients, in terms of confidentiality, this is useful whether you're doing the direct screening method and you're looking for detection and disclosure, or whether you're just wanting to have a conversation. You always want to see the patient alone for part of the visit, and then disclosure limits of confidentiality before discussing IPV. Again, I do this every single time in my work. I saw a patient yesterday. His wife was in the waiting room, and as I escorted him, or I met him out in the waiting room and went to bring him into the office, he said, oh, this is my wife. She'll be coming in with me. I said, absolutely no problem. Just hold on a sec. I'll come right back out to get you. And I brought him in the office, and I said, just so you know, of course, we can bring your wife in if you would find that helpful, but it's also fine if you want her to stay out there and you don't want her to be part of this visit. And I won't even tell her that you wanted her to stay out there. We can just say that I forgot. This particular patient was like, wow, that's really clever. He got what I was doing, but he's like, no, she absolutely needs to be in here. She's really supportive, and she needs to be part of this conversation. But that's a way for you to see the patient alone. And if someone insists on going in to the visit with you and isn't willing to hang out in the waiting room for a minute or 10, then that too is an indication that there's a problem. Even if someone says, yeah, it's okay for my partner to come in, and they're sitting side by side, and he feels like he can't speak without looking at his partner, or she feels like she can't speak without looking at her partner. They're kind of looking for permission to talk. And again, if we were in a room together, I'd see some of you nodding. That's an indication that there are some relationship dynamics that could be potentially problematic. In terms of universal education and empowerment, I'm going to go into a moment into the more discussion-oriented approach to this. You can use safety cards, and I'm going to show you in great detail what these safety cards are. And you can use them to talk with all patients about healthy and unhealthy relationships and the health effects of violence and abuse. And you can give 2 cards to patients so that they can share them with friends and family. And again, I'll walk you through this. Disclosure of IPV is not the goal, but it will happen, even in the non-direct approach, which I'll get to in a moment. You can discuss a patient-centered plan to encourage harm reduction. We'll talk a little bit about this, and make a warm referral to your local provider and document the disclosure. People ask, what does a warm referral mean? A warm referral is not when you give a patient a phone number and say, here's a phone number you can call. I think this is the local provider that's over in, Tuscaloosa or something. It's where you say, you know what, this is the number for the Umbrella Center for Domestic Violence Services. I actually work a lot with Cindy over at that site, and she's really helpful, and you can call this number and ask for Cindy. Now, you might not always have the name of someone, but developing rapport with people at your local domestic violence service provider can help a lot in terms of increasing comfort for the victim survivor to reach out and make that connection. So here's the safety card approach. We've started talking to all our patients about partner violence so they know how to get help for themselves and so that they can help others. Again, I love this approach. It's so creative, and you're going to hear me sing its praises over the next couple of screens. I just think it's really brilliant and speaks to, I did not develop this, just to be clear. It speaks to the folks who developed this truly understanding what it means to work with victims. So you can start that conversation. We started talking to all our patients about partner violence so they know how to get help for themselves and for others. I've started giving 2 of these cards to all of my patients in case it's ever an issue for you, because relationships can change, and also for you to have the information so that you can help a friend or family member if it's an issue for them. Again, brilliant, because they don't have to disclose to you. They can take that card and go, oh yeah, I have a friend, and that may be true, and it may not, but they can still take that information without having to out themselves, without having to disclose. You can open the card and do a quick review, and again, I'm going to show you the card in a second. It talks about healthy and safe relationships, ones that aren't, and how they can affect your health. So this is the title slide that had been moved to earlier. I apologize. If detection and disclosure of IPV is not the goal, you can use this approach that we just started to talk about. And this is what the new card looks like. If you go online, the picture might not look exactly the same as the card you click on if you choose to order them. The cards were recently updated a couple of months ago. So this is what, it's small. It's a business-sized card. It's really cool because it's this laminated paper that doesn't tear very easily, and it's more than a trifold. It folds up multiple times. I have one in front of me at the moment, and there are 5 sections to the card that fold up into the size of a business card that can fit in a wallet or a back pocket or a purse. And it's very broad. It doesn't say anything glaring about domestic violence throughout most of the card. So it asks, how is it going? Here it's just, everyone deserves to have partners who listen to what they want and need. Ask yourself, and again, you don't have to walk through all of these, but the patient in your meeting can look at this card and, take note of what's there. Is my partner, the person I'm seeing, kind and respectful? Are they willing to talk openly? Do they give me space to spend time with others? That is so critically important, because when people limit the individual's contact with friends and family, that is a very key element of psychological abuse. And then it tells them, if you answer yes, sounds like you have a healthy relationship, and that's really helpful for you in terms of your health, a longer life, and your kids. And then it goes on to ask about, are there times? And it has these 4 bullets with X's that ask about times when their partner could shame or humiliate them, make them feel bad, hurt them physically or verbally, make them have sex when they don't want to, keeping them from seeing their doctor or taking their medicine. And it goes on to explain that these experiences are common and that this happens often among women. And again, it doesn't ask for a disclosure, but there's a text number on one of the sides of the card and a hotline that they can call if they want to, and they don't even have to disclose to you. There's a section on helping a friend, that everyone feels helpless at times and like nothing they do is right. It asks or shares information about how you can help a friend, and then separately, if it's true for them too, how it can be useful. This is where there's explicit mention that relationships can affect health, and it says it explicitly. Like, people don't realize that having an abusive relationship, though it doesn't use those words, having a partner hurt you with their words or injure you and make you do sexual things, that can affect your health, and it lists some health conditions like asthma and diabetes, cancer, smoking, substance use, etc., difficulty sleeping, depression. So, and I know to those of us that are trained, we're thinking, well, how could people not know that these things could be related? But most people don't really understand how being a victim of partner violence impacts them in so many ways. And a lot of times it's really useful for them to begin to draw the dots, because a lot of times they feel like there are all these disconnected things that are wrong with them. Look at me. I'm a mess. I can't sleep. I'm anxious all the time. My emotions are out of control. Now I have all these issues where I'm just in pain all the time. I'm starting to drink more than I'm supposed to. And it just feels like, for being more familiar than professional at the moment, they feel like they're a hot mess. And they don't really understand at times that these things are connected. I also think it's important to insert here before I move on to the next card that it's really important to recognize that not all people who experience partner violence experience the negative consequences. So plenty of people who experience partner violence do not go on to develop mental health problems. They do not go on to develop physical health problems that are related to partner violence. They don't overuse alcohol or abuse drugs. So I don't want folks to leave the webinar making assumptions that every person who experiences partner violence is going to have a myriad of problems and are really going to be struggling day to day. There are people on this call, and we're not looking for disclosures that really wouldn't be appropriate, but there are people on this call who've experienced partner violence, and you know that in some ways you're going, yeah, but those things aren't true for me. And so there are protective factors that can be helpful. And so again, I just don't want folks walking away thinking that everybody who's experienced partner violence has a myriad of other problems. It also, I love this one too, it also shows folks like, what does it mean to be a stronger you? I love that it says stronger because it implies that they already have some strength, and really defines what it means to be strong or resilient or come back from these experiences. And it clearly states that they're not at fault, because what happens a lot of times, even if they haven't to disclose to anybody else, is they get blamed by the person who's abusing them. It's all your fault. If you hadn't have done this, I wouldn't have done that, et cetera, et cetera. Finding people who are safe and can help you heal is important as well. Finding ways to manage stress and healthy ways to cope. So it speaks here about maybe you have a good friend to talk to, or maybe you don't yet. Again, great language. And then there are hotlines listed on the card. It's longer than that. There are more panels. I just didn't have time to go into great detail. On the back of the card, there is a safety plan and 24/7 hotlines that have folks who understand complicated relationships. And you can say that to them. You can use the word complicated, right? So that you know when you refer folks to interventions, if we're talking about behavioral interventions for partner violence, they're often provided by domestic violence victim advocates or counselors, or behavioral health providers like counselors, social workers, psychologists, psychiatrists. And often the focus is really to empower victims and develop safety plans. And if it's in the context of therapy, the focus often is or should be on how the partner violence is impacting them day to day, above and beyond the safety and empowerment pieces, right? Because they may be out of the relationship, so you may not need to develop, or the provider may not need to develop a safety plan with someone, but that doesn't mean because they've been out of an abusive relationship for 5 years that it still doesn't impact them today. In terms of the clinic model, there is a way to think about this as not just being something you need to do as an individual provider, or that you might choose to do as an individual provider. As I mentioned earlier, if you're going to take this on, it's really important to have a clinic model so that there's a sense of cohesion and support and collaboration within the clinic about what it's going to mean to take this on. First, it's really important to support staff. If you're going to move toward screening, detection, and disclosure, or even if you're going to use the discussion approach and not looking for detection, it can be very, very difficult to hear people's disclosures of partner violence, and that will influence staff from day to day. I just gave a talk on this to a dental hygienists association a month ago, and there were a number of hygienists who had disclosed how difficult it was when someone came in with, broken teeth, a broken jaw, et cetera, who had disclosed that they were that they had experienced partner violence. So you want to know what that's going to mean for you as a clinic, and do people feel supported, and what can they do if someone discloses to them and it's really hard for them to manage. The clinic model, it would be really useful to connect intimate partner violence to health. I mentioned that before, so I won't go over that again. The safety card intervention is the one that I just shared with you here. I have the link is ipvhealth.org. On the next slide, I'm going to give you, or 2 slides from now, I'm going to give you even more detailed URLs. And then fourth is to have a protocol for warm referral and support. So that really speaks to what I mentioned a moment ago, which is not just a phone number, kind of this cold handoff of here you go ahead and call them. Ideally, if you can give someone the space to call while they're in your clinic, that's even better, because then they can do it privately and safely. I know that that's not always realistic or feasible, but being able to do that can really help someone. I've had a number of patients in my office who I dial the number for them. They're like, yeah, I'd like to talk to someone right now, and I just give them the time while we're meeting. Now, acknowledging I have the liberty to do that, I meet with people for close to an hour, but just to think about what's going to work for you and what's going to work for your clinic. So what more is there to do? You don't want to assume autonomy and free will. And about that, I'm going to bring you back to the comments and the themes that emerged from talking with people about their experiences of partner violence and HIV, where they said that their partners took their medication and flushed it down the toilet, or didn't give them their medicine, or whatever it might be. I think a lot of times as providers, we wonder why people don't follow through with recommendations that we think are pretty easy to follow through on. And so I guess just to now add to the list of things you wonder about, if they're actually able to. Do they have the autonomy and free will to do what you've recommended they do? Considering policies that limit the potential for abusive partners and relatives to influence care. We did talk about this. I gave you an example of that. And you can post flyers for support on the back of bathroom doors or on rack and exam rooms, places that people can take those resources privately. Because I can tell you that oftentimes if you leave those flyers out in a waiting room, people don't want to take them, because that in and of itself is a disclosure if you're taking a pamphlet about partner violence. That safety card approach that I mentioned, the URL has changed a number of times, so I just checked this again 2 days ago. You can go to ipvhealth.org. You can also go to ipvhealthpartners.org. One of them now directs you to the National Health Resource Center on Domestic Violence, but that gigantically long bullet at the bottom brings you directly to the card that I refer to. There are a number of resources, a number of cards. They are available in other languages, including Spanish. So that in particular could be helpful to you to more easily locate the card. And with that, we are going to go to our post-test question, which is there are various forms of IPV that can influence patient engagement in care for HIV, both directly and indirectly, which is the most frequently occurring form of IPV among female victims. Okay. So the poll is closed for voting. And we're going to move on. Okay, so that concludes the presentation portion of the webinar, and we're going to shift into question and answer, and you can type your questions into the chat box. There have been some that have been submitted in advance, some that were submitted while we were having a conversation. Obviously, I'm not necessarily going to be able to answer all of them, but I'll scan them and answer as many as quickly as I can. So there was a question about, is there an obligation to call law enforcement? If you're concerned, it can escalate to a violent outcome. So the response to that is, it depends. If you think someone is an imminent danger, just like you would have an obligation for anyone that you thought was an imminent danger, then it makes sense to call law enforcement. But because you can't really predict, none of us can, not even experts, can't predict when it's going to escalate. That's the whole problem. That's why we do this National Homicide Project, and lots of other folks like Jackie Campbell have done a ton of work on risk assessment. There's no perfect risk assessment. So unless you're certain, unless that person lets you know clearly that they are afraid to leave, that they're concerned about their safety when they go home, there's no obligation to call. Your obligation is really, in your professional ethical code, and unless you are certain that it's going to escalate, which you really can't be certain, then there is no obligation. But you should talk with the person about that. Never, ever would I call the police without having a conversation with that person about it. I just wouldn't let them leave and then call. To share an awful story about a presentation, to be brief, I actually had a provider come up to me and say, well, I've called. And I said, well, just so you know, that can actually raise the risk. He said, I've called the police before. This was the scenario, and, she didn't feel unsafe at the time, but she disclosed, and he was this high-profile doctor in the community. And without telling her, he just called the police, who then went out to her house. And I said, well, just so you know, for the future, that can actually raise the risk of further harm and serious harm to a victim. And unfortunately, this particular provider was much more concerned about liability. And he said, well, that's not my problem. At least I made the call. So I don't really think his head or his heart was in the right place, but that's the response to that in terms of being able to call. Do I have data for the connection between IPV and cancer is the question. Is this secondary to smoking, alcohol use, or something else? That's a really interesting question. There actually is a group in the country now that is doing research on the relationship between partner violence and cancer. And so I really can't speak with a great level of knowledge about what it's related to. We do know that the rate of alcohol use and abuse is very, very high among victims. So my research is done in the context often of community victims, so not necessarily someone who's treatment seeking, though I, of course, do research among that group as well. But women in the community who are not necessarily seeking treatment but participate in our studies, the rate of alcohol abuse is about 58%. And drug abuse is about 48%, and smoking is higher than 70%. 70% of current intimate partner violence victims in my study, of people who are not even seeking treatment, are daily smokers. And so I'm not really clear what the links are yet. I don't think anybody is, but there is research being undertaken on this very topic. Let's see. Is there any adapted screening tool for transgender women? I actually don't know the answer to that. I work with a colleague who does research on partner violence and transgender women, and if I had to say off the top of my head, I would have to say no, because part of what she's doing is really trying to determine how the experiences of partner violence are different from transgender women than cisgender women, and I'm not really familiar with a screening tool on that. We know the issues are different. We actually know that the rates of partner violence are higher among transgender women, transgender men, sexual minority women, people in same-sex relationships. They actually have higher rates of partner violence victimization, believe it or not. But in terms of adapted screening tools, not that I'm aware of. Short of a formal training course, what do I recommend to build the skills and confidence of service providers so they can ask their patients about their experience or fear of violence and respond appropriately? So as I mentioned, that safety card approach is just brilliant. There are lots of tools that go along with that program that can walk you through some ways to build those skills and confidence. Some of it comes with, it sounds so silly, you know, I don't know, certainly I can't speak to the ages of participants, but, you know, most of us are not in our teens. And part of it is building confidence over time in just being able to respond to things that come out of left field, feeling confident that you know what the resources are. If I had to say one thing that could be more helpful than anything else, is connecting with your local domestic violence service provider and asking them to come in and do an in-service at your clinic for staff. It helps you develop a connection. They're more than happy to do that. I have yet to hear about a domestic violence service provider that's not interested in developing a relationship with their local healthcare providers. And so the worst case scenario is when you're dealing with someone who discloses and you're in the moment and going, that webinar didn't cover this, and I have no idea what to do right now. It's okay to say, you know what, whatever their name is, Tami, I'm really feeling like at this moment, I want to be able to provide more support to you, and I really think it could make sense for me to reach out to Cindy at the Umbrella Center for Domestic Violence Services. Would that be okay? Because I'm really feeling like I'm not sure how to be supportive in the moment. People will appreciate that more than you trying to wing it in a way that could increase their discomfort or be offensive, et cetera. So that would be my one recommendation in the moment, is to have someone come in. And then you can learn about the resources they provide, because all domestic violence service providers, though many of them are funded by the Office on Violence Against Women, they don't all provide the same services. So some folks provide individual mental health counseling, some don't. Some provide group treatment, some don't. Some provide substance use treatment. Some provide shelters, others provide transitional living programs. Some provide legal support and advocacy for folks who are wanting to get out of their relationship but need support to do that, and others provide services for kids. There's also, this is important I think too, in a lot of communities across the country, there are what are called family justice centers. And if you have a family justice center in your community, it might not exactly be called that, but family justice centers are one-stop shops. It's kind of a terrible way to say it, but that's what they're aiming to do, is they're aiming to be a one-stop shop for victims of domestic violence, so that, for example, if there is someone who's wanting to leave, so that the victim doesn't have to go to the police department to pick up a report, then to the domestic violence service provider to learn about resources, then to the child advocacy center to see if she can find a therapist for her kids, to the, I mean, I can go on and on. Some family justice centers are amazingly comprehensive in some states and in some communities. They have everything from dental clinics that provide free dental care to job training services. So you can also check out if there's a family justice center in your community or in a nearby community to see what kind of services and supports they offer. So someone asked, what evidence is there linking alcohol use and abuse among men and perpetration of violence? Overwhelming evidence. There's overwhelming evidence that alcohol use and abuse is related to perpetration of violence. But let me be clear, there are a ton of abusive relationships where neither one of them uses substances. So I just want to be clear about what that means. Yes, There is a relationship between substance use and perpetration of violence, but there are just as many relationships where substance use is not associated. So again, I don't want people to walk away thinking, well, this is only an issue for people who use or abuse alcohol. It certainly disinhibits people. There are all sorts of other problems, but just to be clear, it's not only about that. Partner violence. Are women always the victims? Absolutely not. As I mentioned a moment ago, partner violence can be in same-sex relationships. It can be among people who are cisgender, transgender. It's certainly not always women. As I mentioned, I've done these talks a lot of times in different contexts for different types of providers. And I always do one annually for the Yale New Haven Health System. And last year, there was a provider who walked up to me. Now, and I believe in our state, they don't have to attend, the MDs don't have to attend, but every 6 years or something like that, 5 years. This gentleman came up to me and said, I come to your talk every single year. And the reason I do is because I am a male victim. My ex-wife was very physically abusive, and she was, having a hard time at work, and she would come home and she would just have no self-control, and her emotions were all over the place, and she would abuse me in front of the kids. And you were the first provider that I've ever heard talk about male victims with a sense of belief. It's so common. It is not just about women victims. With that said, women tend to be victims far more often because of the differences in size. Physical abuse, injuries, and consequences tend to be much greater among women. And certainly we need to put it in the context of motivations for use of aggression, which I've done a ton of work on over the years. We can't assume that just because two people use aggression in a relationship that both are quote-unquote abusers. It's really important to disentangle that and understand the motivation for use of aggression, because if my spouse and I are in a relationship and he pushes me to the ground and I kick him off me for safety, someone could look at that and say, well, look, she used aggression as well, so she's just as bad as he is. But we really need to put that in the context. That could be in self-defense. So to better understand that, I think, is important. But absolutely, victims can be of any gender identity. Is there a lot of evidence on occurrence of IPV in financially independent women? No, and that is one of my dream studies to be able to conduct. One of the challenges with having these statistics and better understanding how it affects people is willingness for people to participate in research studies. And so you have to figure out what might make people interested in participating and how to recruit them for participation. And financially independent people, people who are working full-time plus, et cetera, are very difficult to recruit. I participate in surveys on the phone and studies and things like that because I believe in the importance of that, but lots of people don't have time, are not interested. So there is not a lot of great data. There are a few researchers whose names escape me in the moment that have shared that they have been able to recruit high-earning women to better understand partner violence, but there's very, very little information out there on that. Let's see. Oh, I have to scroll. Are there validated brief 10 to 20 question low literacy IPV questionnaires that you recommend using for research purposes, either as an outcome or predictor variable? CTS, who, et cetera. This is a tough one. So as I mentioned, I do a lot of research. For folks who don't know, the CTS stands for the Conflict Tactics Scale. It's quote-unquote the gold standard, but if I can say out loud, it is the worst gold standard of any measure. I don't think it does a really good job of putting the partner violence into context. There are briefer items, and for folks who are interested, the National Institute of Justice, who's funded some of my work, they actually have a compendium of IPV assessment tools, and they have it for adults and for kids. So if you Google National Institute of Justice compendium, you can find that. And it actually, what's great about that, you can actually order it free and have it shipped to you. It's a spiral-bound, pretty thick book. It allows you to really scan the different ways in which people have developed measures and what might be useful for your purposes. And they do have some that are specific for just women, for just men, et cetera. So I would direct you to that. That way you can identify which is best for your purposes. And this probably is the last opportunity I have for a question, is the passive interference confused with codependence, perhaps, of the alleged victim, and that codependents, interfering with their care? I apologize, I'm not sure that I understand that question. Is the passive interference confused with codependence? I'm not really sure what someone means by codependence, but it depends on how you operationalize that. I mean, if my partner is the one with a car, or the one who works while I stay home with the kids, and she doesn't want to stop and pick up my medication on the way home or pick up money, I wouldn't call that codependence in the way that we think about it in the terms of substance use. Like, lots of times people think of the term codependence in the context of alcohol use, and so I don't want to put it in that context because that's pejorative. So I'm not really sure that I understand. I guess I would need more context around that. And then, do I have one more? When I talk to clients about IPV, they often ask about interventions for the perpetrators. What's the evidence availability of this? Oh, very good question. So this truly is my last comment because it is 2:15. So interestingly enough, I happen to be a victim service person and a victim researcher who also oversees interventions for domestic violence offenders, because I think who better to oversee such a program than someone who understands victims. So the state of Connecticut, I oversee a first-time offender program. There is terrible evidence for batterers' intervention. So the National Institute of Justice has funded a tremendous amount of research over decades with little showing any effect or efficacy. However, there are newer treatments being developed, and there is one that demonstrates particular promise. And her name is Amy Zering. She's the researcher who developed it, and it's the acronym is ACT, A-C-T. And it's really focused on emotion regulation and really seems to have strong evidence. So she's been funded by the National Institute of Health, and I can't recall right now if she's being funded for another study by the National Institute of Justice or the Office on Violence Against Women. But there is stronger support for that than anything we've seen to date, which is really, really promising. So I think, unless somebody else tells me, I think we're supposed to stop now. Jose, is that true? I think so. So I'm going to go ahead and go through the rest of the slides, show you where the webinar will be available for on-demand viewing and